Hello, ladies and gentlemen, and thank you so much for a new season from Brain Talk. And this time we'll talk about the ventricular puncture points. It's my honor to introduce you to this new lecture from ventricle, puncture points. As we see here, this is the ventricle system. Here is the frontal horn and the lateral and the lateral. I'm sorry, there is a lateral ventricle, and this is the frontal lateral body, and this is the trachea, and here is the temporal horn and occipital horn also here. So we have here actually more access to the lateral ventricle. We have the anterior access points, and we have the side, or side ventricle points, and also in the back of this of the brain. Also, we have points for introducing a catheter in the lateral ventricle. So ventricle access is one of the most common procedure, and the tip of the catheter, should placed near the foramen of Moreau, because the foramen of Moreau, is free from the choroid plexus, and the adhesion and occlusion of the catheter will be more unlikely. So it's safe to place the catheter on the patient right side at most of the patient, because the right side is the dominant side, non-dominant side of the brain, and an injury to due to the catheter cannot induce any neurological deficit for patient. But actually, sometimes we do this on the left side according to the anatomy, according to the pathology, according to the compression of the ventricle system. So our these pictures in this lecture is coming from the operative cranial neurosurgical anatomy, and also from the craniometrics and ventricle axis review for points of the ventricle written by Morin and Michel Diwan. So we're starting from the anterior axis side. Starting from the cohort points is here. Its location is 11 centimeter superior and posterior from the nasal, and 3 centimeter lateral to the midline. And we can also have another location is along the mid pulmonary line, and is 1 to 2 centimeter anterior to the coronal suture. Our trajectory is an angle that is perpendicular to the intersection of lines drawn from the ipsilateral medial canthus and ipsilateral external erythematous. So catheter should be passed, give up approximately 6 centimeter, or where there is a CSF coming out. The tip of the catheter, as we said before, should be placed near the foramen of Monroe. As we see in this picture, here is the mid. This is the nasal. Here is the 11 centimeter from the nasal and 3 centimeter from the midline, and this is this entry point. And our trajectory is an intersection line between the ipsilateral medial canthus with the ipsilateral external erythematous. And our depth will be like 6 centimeter, not extends above this number. Here another picture for cohort points is like 1 centimeter from the from the coronal suture, and in the mid-bubular line. Kaufman's point is a rapid access to the ventricle system for emergent draining of the CSF. Location is 5 centimeters superior to the nasal and 3 centimeters lateral to the midline. Our trajectory will be, towards the midline and inferiorly towards the point where is 3 centimeters superior to the anion. And the catheter should be passed approximately 7 centimeters. As we see here in this picture, This is the 5 centimeter superior to the nasion and 3 centimeter lateral to the midline. So our trajectory will be like to the midline, and inferiorly will be like 3 centimeter above the anion. The depth will be 7 centimeter, all according to the ventricle size. Here is the Kaufman point, as we see here in this picture. It's like 3 centimeter from the midline, 4 to 5 centimeter above the above the nasion. So we have also the Payne's point. So Payne's point is employed when there is a concert to severe brain edema after complicating the frontotemporal craniotomy, and the location is 2.5 centimeter above the floor of the anterior cranial fossa and 2.5 centimeter anterior to the Sylvian fissure. So intersection of these lines forms the anterior and posterior limbs of the Payne's triangle, and the catheter should be advanced 4 to 5 centimeter. So the Payne's point has a risk of damaging Broca's area and the head of the callus nucleus and the thalamus. As we see in this beautiful picture, here is the anterior fossa, this frontal lobe. Here is the temporal lobe. Here is the Sylvian fissure. So here is, the Sylvian fissure, and 2.5 centimeter, and 2 from the anterior cranial fossa, and 2.5 from the Sylvian fissure. Intersection point will be the Payne's point, as we see in this this picture more clear. And here is the anterior cranial fossa. Here is the Sylvian fissure, and 2.5 centimeter from the Sylvian fissure, and 2.5 centimeter from the anterior cranial fossa. So the intersection point will be like the Payne's point, and our trajectory will be perpendicular, and the depth will be 4 to 5 centimeter, or according to the ventricle size. Also, we have another points or modified for Payne's point. This is a Payne's point, as we say here. This is the anterior cranial fossa. Here is the Sylvian fissure, and the intersection between these two lines will be the Payne's point. So the modified of the Payne's point is Hayun points, is a Korean doctor who's estimate or put extending 2 centimeter from the anterior lip of the Payne's triangle, as we see here in this picture. Here is the Hayun's point in the red color, is extending of the anterior limb of the Payne's point, 2 centimeter above the anterior limb, and this is the entry point. The entry point will be 5 to 6.5 centimeter to the frontal horn. Another modified point is called Park's point, and it extends from the posterior limb of the Payne's triangle, and the catheter should be perpendicular to the convexity of the brain and pass 5 to 6 centimeter. Here is the Park's point, as we see here, extending from the this is the posterior limb, this is the anterior limb, from the posterior limb 2 centimeter, and as we say is like 5 to 6 meters perpendicular on the convexity of the brain. Another point is Minovsky's point, is while performing supraorbital craniotomy, we can use through the eyebrow. We use this Minovsky's point. The catheter should be passed through a bar hole, especially the keyhole, and directed 45 degrees towards the midline and 20 degrees superior to the orbitometer line. The depth will be 5 to 6.5 centimeter, or according to the ventricle size will be the number. This number will be exchanged. Here is the supraorbital approach. This is the keyhole here. As we see here, we directed our catheter is 45 degree from the midline, and is like 20 degrees superior to the orbital line, and the depth will be 5 to 6.5 centimeter to the frontal horn. We have the top point is can this point is during the emergency for decompression the ventricle system via transorbital route and completed with a spinal needle. Trajectory is like 45 degrees superior to the orbital line and 20 degrees towards the midline. The orbital roof should be penetrated just medial to the mid-patellar line and posterior to the superciliary arch. The depth will be like 8 centimeter, or according to the ventricle size. So here is our spinal needle. The spinal needle is directed 45 degree above the orbital line, and medially is like 20 degree medial to the mid-patellar line, and the depth will be 8 centimeter. Here is the transorbital point or Taus point. So after finishing the anterior axis point or size, we move to the posterior axis side. Here we have firstly the Keynes point. The location is 2.5 to 3 centimeter superior, and posterior to the pinna of the direction is slightly cephalic direction, and position is perpendicular to the temporal lobe cortex. The depth will be 4 to 5 centimeter or until reaching the trigone. Here is our key points is 2.5 to 3 centimeter above and posterior to the pinna. The depth will be like 4 to 5 centimeter. Frazier point is location is 6 centimeters superior to the inion and 3 to 4 centimeter left or right to the midline, and direction will be medially and superiorly to the point that lies 4 centimeter above the contralateral medial canthus. The depth will be like 5 centimeter until reaching the ventricle system, and after that advancing the catheter without stylet will be like 10 centimeter. As we see here in this picture, here's the inion is 6 centimeter above the inion and 4 centimeter lateral to the midline, and our direction will be exactly to the opposite or contralateral medial canthus, 4 centimeter above the contralateral medial canthus, and the depth will be 5 centimeter until reaching the the ventricle system. After that, you take at the stylet and advance more 5 centimeter, and the long will be, or the depth will be like 10 centimeter. Here is the Frazier point of the skull, as we see here, and this is dandy points. Dandy points location is 3 centimeter above the inion and 2 centimeter left or right to the midline according to the pathology. So the direction will be 2 centimeter above the glabella and bears to the distance of 4 to 5 centimeter or anterior CSF is encountered. So the disadvantage of this point is damage to the visual fields. As we see here in this picture, here's the inion, 3 centimeter above the inion and 2 centimeter to the midline, and our direction will be in the same direction medially and to the same ipsilateral glabella, 2 centimeter of the glabella. So after that, this is the dandy point on the skull, as we see here, 2 centimeter, from the midline and 3 centimeter above the inion. Sanchez point is used to the temporal horn, is employed to divert CSF in the setting of trapped ventricle or the endoscopally during the endoscopic approach to the mesotemporal structure. The location is 5.6 centimeter above the inion and 2.7 centimeter left or right to the midline. I directed is 5 degree lateral from the parasagittal plane and 30 degree inferior to the orbitomedial line, and the depth will be 9 to 10 centimeter. As we see here, here is the inion and 5.6 above the inion and 2.7 from the midline. Our direction will be like from the midline is like 5 degree, and inferiorly is 3 degree from the orbital medial plane. So our tip will be in the temporal horn. So moving to Sean's more used points, we have the occipital parietal point. So firstly, how to localize this point? Firstly, you measure a mark halfway between the external acoustic meatus and the inion. Second, measurement is made, halfway between this mark and the vertex of the skull. So we'll, find a flat area of the skull, exists just superior and posterior to this mark. As we see in this picture, firstly, draw a line from the external meatus to the inion, and the halfway of this picture of this line, you draw a line to the vertex, and halfway of this line, you must mark it. After that, you superior or posterior and inferior to this point, you will find a flat area, and actually it will be like the entry point of your catheter. As we see here, we marked the first line and point for A point. After that, from A point to the vertex, we make a B point, which is the halfway of this line, posterior and superior to this point. This is the flat area. It will be the entry point of your catheter. We have lastly the points. The points is the same as occipital parietal point. How to find this point is 1 finger breadth posterior and inferior to the parietal bows. As we see here, here's the parietal bows, and behind it here, superior to the parietal bows and posterior to the parietal bows. It will be your this will be inferior to here. Inferior. This is the parietal bows. Inferior to the parietal bows, 1 finger breadth, and posterior to the parietal bows, it will be your entry points, or it's called nose point, as we see here. Here's the parietal bows. So 1 finger breadth will be inferior to these bows, and 1 finger breadth will be posterior to this finger. 1 finger will be posterior to the parietal bows, and we will find the nose point, and we use this semilacunar incision for our shunt operation. By this, we'll finish our ventricle puncture sites. Thank you so much for your attention, and we will be attached in the next season of Brain Talk. Bye-bye.